Good evening, everyone. I would like to welcome you in our Saudi Association Neurosurgical Society in SANS Academy webinar series. Today, it's our pleasure to have Dr. Mahmoud Taha. He's a consultant neurosurgery, head of neuro-oncology program in Dammam, Saudi Arabia. Today, we'll talk about the management of glioblastoma in adults. Thank you, Dr. Taha, for your effort and contribution to our webinars.
Welcome. Assalamu alaikum. Good evening, everyone. My name is Dr. Mahmoud Taha. I'm a consultant neurosurgeon at King Fahd Specialty Hospital in Dammam. I would like first to thank SANS Scientific Committee for giving me this chance to present again in this webinar. So today we will cover the management of glioblastoma in adults. We will go through the guidelines and some controversies and clinical tips throughout the presentation. The objective of this presentation is to review briefly the management of GBM. We will review the current guidelines. We will go through the evidence-based management of this tumor. I'll try also to cover the basics of treatment. This is really important for the residents, and to mention some controversies in treating GBM. We have to mention also the practicality and cost-effectiveness of some treatment. There are some ethical aspects that we will mention very briefly. And the tips I'm going to mention here, this is from experience that we have in treating GBM over the last, center, last 12 years, 13 years. And I'm going to mention this very, very briefly because this was covered in the previous two presentations that we've done before, and when we talked about the new WHO classification of CNS tumor. We went through the new WHO classification with regard to gliomas, and then glioblastoma in adult and pediatric. So we're not going to go through this again, and please go back to the previous presentations. These presentations are on the net now on the SANS YouTube channel. But before covering the management of treatment of GBM, I need to mention this because this is very relevant, the incidence of GBM. This is relevant to our practice here in Saudi. And it's very important for the resident to understand that the glioblastoma and the incidence vary from country to country. This review that was published 2009, the incidence of glioblastoma really variable between countries, and it ranged from 0.59 to 3.69 per 100,000. So it's really the highest is going to be in the Western society, North America and Europe, lowest in Middle East. And you can see here in 2014, the Saudi Cancer Registry had 349 cases of malignant brain tumor. Third of them were GBM. So roughly, we estimated that the GBM incidence in Saudi Arabia per year, per 100,000, is about 0.4. So if you are working in an oncology center that cover, let's say Eastern Province, for example, and we have 4 million population. So if it is 0.4, that means 4 per million per year. So we'd expect around 16 cases per year, and that's what we normally receive. We receive between around 12, 14 cases per year currently, and I think rest is treated in other hospitals or in Riyadh. But in our center, we are the only Ministry of Health oncology center. So most of the GBM would come to us for treatment, for adjuvant therapy. And this is the table of Saudi Cancer Registry in 2014. You can see here that the GBM third in male and female. Obviously, it's more in female. This is internationally, more in male than female. So a third of malignant brain tumor are GBM. Similar to our review here, this is a study that we published before. Again, third of the primary brain tumor, not primary, sorry, neuroepithelial tumor are GBM. So the incidence of GBM in this region is low compared to other countries, compared mainly to North America and Europe. Thankfully, it is less. However, the age is slightly different, but the age internationally is around, especially in Western countries. Most of the studies come from Western countries. North America and Europe is roughly around 60, 59, 60. In Saudi is roughly about 50. And this is a nice study by in King Fahd Medical City, Dr. Larry. They published this before. So they have 90 cases. The age was 49. So roughly around 49, 50 years old. This is the average age for GBM in this. So it's younger, slightly younger than the average age in Western countries. And you can see here also the number of referral in Riyadh, you know, in this centers, obviously Riyadh have many centers, but, you know, between 14, 18, 20 cases per year. And again, you can see here the average age in our country, in our Eastern province, the top is in the 50s. While in USA, the incidence or the age of GBM goes up, you know, by decades. So this is really important to remember, especially for the residents. Now, the treatment of GBM is, you know, is extreme. This is, if you look at the literature and you know, Google search, you would find thousands of research, because this disease is extremely aggressive. There's no cure, and you know, the survival is still trivial. It's 1 or 2 years. You know, there is improvement now in the survival with different treatment that we have now. Still, you know, one of the deadliest tumor in the body. And I've just summarized in this slide all the, you know, the common research fields in the management of GBM, starting from surgery. You know, this was the oldest treatment, obviously. The radiotherapy, different type of radiotherapy, you know, conformal radiotherapy, stereotactic radiotherapy, brachytherapy, proton beam. This is all being tried. Systemic chemotherapy, a huge number of chemotherapy used. Local chemotherapy, target therapy, convection enhanced delivery. This is again some sort of local chemotherapy where small tubes implanted in the brain with constant flow of chemotherapy injected in the brain. Again, still under trial. Electric field therapy. This is becoming popular. There's we'll talk briefly about it. Again, does have some evidence. Ultrasound focused therapy. This is using ultrasound energy to disrupt the blood-brain barrier and allow better penetration of systemic chemotherapy. Laser ablation, we heard about it. It's being used, again, not promising. Viral gene therapy is being used, injecting tumor with virus or part of the virus and then treating them with antivirus. Stem cell being tried. Immunotherapy, again, huge number of studies. Immunotherapy. I think the most promising thing, which has been just published recently, is about the intrinsic cell vaccine. I'll mention this very, very briefly. So a lot of research, but few of them has matured or materialized into a standard of care or you know, proper or clinical application. Okay, now this is basically what happened and the survival of GBM and the improvements that happen, which I would say it's, you know, slight improvement in GBM over the last 50 years. And I've mentioned here briefly the time of the papers or the trials that's been published and influenced the management and the survival of GBM. So initially, obviously, if you don't treat the GBM, patient survival is going to be a few months. If you do surgery, this will be improved between 3 to 6 months. In the 70s and 80s, obviously, a lot of studies on radiotherapy effect on GBM. That brought the GBM survival up to 9 to 11 months. Then a lot of chemotherapy agents used didn't show beneficial result. However, local chemotherapy came up with by using carmestin and showed some benefit. This was started in the 1995 for recurrent GBM, then for newly diagnosed GBM. We'll cover this briefly and gave slight improvement in survival up to 13 months. Shortly after FDA approval of local chemotherapy, a stop protocol came when temozolomide introduced and found some effect on the good effect on treatment of GBM. The stop protocol was obviously the paper published 2005 and showed some benefit. It was big randomized study, proper study, and improvement of survival to almost 14.6 months. Then the same group published 2015, like 10 years later, the same agents for stop protocol with the electric field therapy or tumor treating field and showed more improvement in the survival of GBM. We'll talk about this very briefly. And very recently, 2018, the dendritic cell vaccine improvement up to 23 months. I'm not going to talk about this because something very new and it's not included yet in the guidelines. But there's something to report. This is a randomized trial, phase 3. A good number of cases, more than 150 patients. But this is something worth mentioning because it might be coming up in the next guidelines or next recommendations. This is something very important for the resident and decision making to remember. Prognostication of GBM or survival. We have now the molecular, which we talked about last time. Very important, the IDH, the MGMT methylation. IDH, we know that the IDH wild type is which we used to call the primer or de novo GBM. This prognosis is worse than secondary GBM. So when we talked about treatment of GBM, most of the time we mean the wild type IDH, the de novo, not the secondary GBM. Methylation, better prognosis, age, extremely important. Extensive resection, this will be covered. Clinical performance, very, very important prognostic factor. And most of the study used the Karnofsky score, and this is the cut for good prognosis and bad prognosis, above 60 or 70 and above. This is where the patient is independent. Anything below patient is dependent, so dependent, and their management will be affected. So these factors, mainly age, extended resection, clinical performance, has huge influence on the management of GBM, and we will cover this now. So this is very, very well known, with up to the strength of evidence or any study or recommendations. So everybody should be familiar, especially the residents, when reading about recommendations or guidelines. So the strength of evidence, as you can see, from 1 to 5, this is well known. Grade 1 when you have randomized studies with good methodology. small randomized, meta-analysis also is a great one. And then we have the prospective study, 3, 5 is case reports. The grade of recommendation also A, B, C, D, E, based on the strength of studies. A is the best, basically strong evidence. And I'm just gonna put here this table, which summarize all the evidence and the strength recommendation. This is actually something between European and American. I think it's approved by both of them. Recommendation of the American, the NCCU, and the European slightly different in terms of radiation, but otherwise it's probably the same. And this study published by the Spanish Neurological group, and depending on American and the European recommendation and guidelines. And I like this table because it shows also the level of evidence and the grade of, the strength of evidence. And you can see here, this summarizes all the recommendation and the management of GBM, that the first thing, as we mentioned, prognostication, Karnofsky score, neurological function, age, and degree of resection is a very important prognostic factor, and this is class 1 evidence. The diagnostic imaging of tumor has to be MRI scan. The maximum surgical removal is class 2 evidence. The PCNU Camerton wafer, this is what we're talking about, the local chemotherapy, is class 2, C recommendation. This is very important. MRI scan has to be done within 48 hours, I would say, maximum 72 hours after surgery. This is also a strong recommendation. Any histology we'll do nowadays, it has to include the MGMT, promoter methylation, and the IDH, also recommended, because it's influenced the management, treatment of GBM, and also prognosis. The follow-up after treatment with the MRI scan also, it's recommended to follow up on the response of treatment and developing pseudo progression. We'll talk about this later. And this is the adjuvant therapy after surgery. So for newly diagnosed GBM, because when you read the studies to treatment of GBM, you have to make sure that you're reading the right thing. Newly diagnosed, recurrent GBM. For newly diagnosed GBM, so you can see here, it's all depend on age, below 65 or 70 and above. And then you need to look at the methylation, MGMT, and performance. So the patient, if the patient is below 70, you have to give radiotherapy, 60 gray in 30 sessions, plus concurrent temozolomide, followed by temozolomide 6 cycles. So this is over 6 months. Okay, if performance is, this is, sorry, not mentioned here, but if patient above 65 or 70, consider radiotherapy plus concurrent temozolomide, followed by adjuvant temozolomide for 12 cycles. Okay, that's based on some study for elderly patients. If the patient had poor performance, Karnofsky, unfit, we call that unfit. So that Karnofsky is below 60. We have to provide what we call hypofractionation radiotherapy, 50 gray and 28 fraction. If it is, if he has MGMT methylated, you can give him temozolomide. It's similar to radiotherapy. So what influence the adjuvant therapy of GBM is maybe 3 things. Your age, the age of the patient, the performance, Karnofsky, and also the MGMT, the methylation. These are the 3 factors, providing that you've done a good surgery for these patients. And this will be covered shortly in the next few slides. So the first thing I'm gonna talk about is the surgery. Where did we get this? Extension of resection, extent of resection. Extent of resection, EOR, this was first reviewed really in a good paper in MD Anderson Cancer, Houston, and published in 2001. Probably this is the first, one of the big studies that showed that the more you resect, the better prognosis you get. However, they came up with this table, which I thought it's important to mention here. When you grade the tumor according to location into grade 1, 2, 3, with regard to location near elegant area of the brain. So can be grade 1, where the areas are far from elegant brain areas, motor sensory, or deep corpus callosum, speech, dentate nucleus in the cerebellum or brainstem. Okay, so if it's either non-elegant or near elegant area, grade 2, or 3, which is elegant area. And elegant area, most of the time we talk about biopsy. Near elegant area, you could try subtotal resection. Non-elegant area, you should aim for total resection. That was what's been, as residents, been advised to do. The conclusion of this study, by the way, this study, 416 patients, include GBM, recurrent or newly diagnosed and recurrent GBM. When they looked at the untreated patient, that means a newly diagnosed GBM, the extent of resection, when you achieve more than, this is the figure they gave, 98%, this is where you get significant statistical difference. Okay, so your survival improved from 10, 11 to 13, so from 11, 12 to 13. This is the median survival. So to get significant statistical improvement in survival, which is basically 2 months, you have to achieve more than 98% resection of the tumor. And this is where what they call resection threshold came about. And this is what we call minimum resection requirement, or the minimum resection threshold in resecting GBM and achieving better prognosis than the usual debulking, partial resection debulking, followed by radiotherapy, which I said it's 9 to 11 months. So if you achieve more resection, up to 98%, you achieve extra 2 months. Okay, so this is the first paper that talked about extent of resection and the relationship with improvement of survival. However, obviously, I mentioned this. The study include both newly diagnosed, recurrent, and there are some selection criteria. I think most of them were 10% were deep Karnofsky score. Majority of patients were good Karnofsky score, and this study actually covered 93 to 99. So it's published 2001, pre to the STOP protocol. There was no molecular testing at that time, and the emphasis is very important: resection of the enhancement part of the tumor. Okay, according to them, morbidities were similar if you do total resection compared to near total resection. So this study showed, as I mentioned, that maximum site reduction is very beneficial, and there was we have this term now, extent of resection threshold. However, in San Francisco, published later another study which brought down the threshold of extension of resection of the enhancing part of the tumor down to 78%. This group showed that the result achieved by the MD Anderson study, 98% resection and above, can be achieved in their study by doing more than 78%. So their threshold dropped to 78%. Okay, so this is what we are trying to cover, the controversies of in GBM management. So this is the controversies in surgery, deciding what is the extent of resection, what is the threshold for minimum resection to achieve better prognosis. So this study of Berger study in San Francisco, 500 patients between 97 and 2009. Remember here, some of these patients have sub-protocol. And they define gross total resection as resection more than 95% of tumor. So at this stage, more resection is better. The focus on the enhancing part of the tumor, and the threshold now, the minimum threshold to achieve better prognosis than the usual debulking plus radiotherapy is, 78% or 98%, depending on the study. Now, to move further, the same group, the MD Anderson, again did further study, which was published in 2016. And so they have now larger number of patients. They have 1,229 patients. And their paper was, can we do better than cross-total resection? So we're talking about now resecting not only the enhancing part, but also the T2, the flare, T2 flare MRI tumor infiltration. And you can see that on the very clearly on the MRI scan here, enhancing part compared to the flare. And on the top one, you can see the extension of tumor. This flare obviously show you more, better than T2. T2 would tell you more about the edema. If you use the flare, it reflects more on the tumor infiltration. And this picture on the top is really nice because what you've seen as enhancing part is actually part of the tumor. The real tumor is actually, when you see on the flare, it's the spread infiltration, which goes to the corpus callosum and the basea thalamus. So this is the real extension of the tumor. And same thing for the bottom one, a small enhancing part, tumor. The real extension of the infiltration is much bigger. So this study, which was published, as I said, in 2016, they combined their previous group with the newly operated patients. So it's from 93 to 2012. For that group, they select all the patients had cross-total resection. Total resection, 100% resection, 876. And that, constitute about 70%, 71% of their patients. These patients had median survival of 15.2. So you can see now the survival is better than the previous study because these patients, some of them had stop protocol. So that added to their survival. What they did, they compared the 100% resection, first of all, with the survival of patient who had 79% to 99%. So they used the threshold suggested by Berger's study, which is 79% and above, and they to make the comparison. So these two groups, there was a significant difference. So 100%, you get 15.2 overall survival median. The other group, which has the 79 to 99% extended resection, they have 9.8 overall survival. Then they did subgroup analysis to the patient who had not only resection of the enhancement part, but the flare T1 resection. So this is all retrospective analysis. So when they looked at the patients who had more than 50% resection of the flare involvement of the tumor, they achieved much, much better survival compared to the patient who had less than 50% resection of the flare, tumor involvement. So if you resect the enhancing part plus more than 50% of the flare, your survival is going to go up to 20.7 survival, median survival, overall survival, compared to 15.5 if you resect the enhancing part plus less than 50% of the flare involvement. Okay. According to them, I looked at the complications. 30 days complication in all group which had 100% resection was 25%. Deficit was 19%. This is 30 days. Nothing mentioned about long term, but according to them, no significant difference from the other group, which have less resection. Okay, so now we're gonna move from not only resecting the enhancing part of the tumor, but if the tumor in a non-elegant place where you can resect more and go for the flare, involvement on the MRI scan, your prognosis will be even better. Again, with the excitement and the improvement of survival with more resection, people went even further to consider resecting tumor in places where it's considered before as no area, forbidden area, like butterfly gliomas or multifocal glioma. Again, this is still very, very controversial. And the studies that we have, for example, on butterfly glioma, there's a small number of cases, survival of partial resection of disease. If you achieve a good resection of the butterfly, obviously you have to go from unilateral approach to resect. And if you can do that, obviously without influence the cognitive of the patient, you can achieve better survival. So this will bring you to 12 months compared to 8 months biopsy only. People talking now about resecting multifocal GBM. If you have multifocal GBM, one of them is dominant and big, and you can resect the bigger one. You can also achieve better prognosis. Again, this is all the small studies are still controversial. People talking about also deep-seated thalamic GBM, trying to resect. These cases does have a high morbidity and neurological deficit. I think we need to be careful about this, but we never know. We just need to collect bigger sample, bigger number of patients, and see the survival and the outcome. The reason for considering the age and the performance as important in determining the survival and prognosis of GBM is shown very clearly, very nice on this study. Published in 2014. It's again MD Anderson. So they try to come up with predicting kind of scoring system that would predict the survival, depend on these factors, extended resection, age of disease, performance, whether you receive radiotherapy or temozolomide, and they can give you some expected figures of survival. And this is really important to show that in patient less than 70, and they gave this example, patient age 40 with good performance. If you move your resection, if you achieve resection from 75%, for example, to 95%, you gain at least 135 days. Okay, so that's more than 3 months, almost 4 months. But if you do the same thing, patient who's 84 with poor performance, you only gain 55% for some reason. So if the patient is older and poor performance, try to be less aggressive in resection, because even if you do more, the survival benefit is less, okay? The next question now is how can we achieve maximum safe resection of these patients? Obviously, we do have tools and a lot of adjuncts that we can use nowadays to improve our maximum safe resection, and I emphasize on the safe resection. We have now MRI navigation. We can use it with contrast enhancing, non-contrast enhancing, with the flare. We need to have if the tumor near the elegant area, especially motor area or speech area, you have to have the function MRI, DTI. If you have intraoperative MRI scan, that will assess for you extended resection intraoperatively, and then you can extend your resection. That would be brilliant. If you can achieve awake craniotomy, that is really excellent method doing maximum safe resection. If you don't have it, you can use intraoperative monitoring for motor and sensory. And finally, we have now the fluorescent fiber A, again to give you the the extension of the tumor and the infiltration. And this is shown also in a lot of studies. It will improve your survival of the patient, and you can achieve more resection, especially beyond the enhancing part. And I'm mentioning this study because this is important to mention. This is a German study, and they looked at their 149 patients, newly diagnosed GBM, and they compared their survival and extended resection before having neuro-oncology dedicated center. So first of all, they found that when you do more resection, obviously you get better survival compared to less resection. So if you achieve complete resection, you have survival of 18 months, 18.4 compared to 14.5 with less resection. The morbidity and transient permanent post-neurological were similar, but more important, the frequency of complete resection. So how often you can achieve, complete resection. If it's done, when it's done in the era of neuro-oncology dedicated center, they achieve 68% complete resection compared to 34% of before having a neuro-oncology dedicated center. So that reflects on the not only the expertise of surgeons, but also the availability of all these adjunct surgical tools to maximize your resection safely. So this is surgical resection, and what we are, the update on the, the surgical aspects of GBM. And the basics behind it. I'm just going to give you, this is mainly for the residents, some basics about principles of radiotherapy and GBM, just for the resident to understand, the principle of how we give radiotherapy nowadays for GBM. So we know the evidence is strong for GBM, and a lot of studies in 1970s, 80s showed the improvement survival from 3 to 6 months with only surgery or palliative to 9 to 12 months surgery plus radiotherapy. And we mentioned the current guidelines. So we have now 3 areas that radiation will focus. So we don't use whole brain radiation as before. We have now conformal radiotherapy, and we have, we have to define first the area of resection of what we call the tumor bed, gross total volume. This is the white thing. Then you have to extend further to the green area, what they call it the clinical total area. So this is 2-3 centimeters beyond the area of resection or beyond the edge of the tumor, the enhancing part of the tumor. So they will include the T2 flare. And then you have a zone of about, I think it's about less than 1 centimeter for the planning errors or variation day by day, treatment. If the patient had decided that it will be for palliative, you give him hypofractionation with a less dose on a lesser duration. So what are the controversies in radiotherapy? The most common thing is the timing of radiotherapy. And this is very important. So you've done your surgery now, you did hopefully good resection. The second question you need to ask yourself, when should I refer the patient for radiotherapy? Again, this is controversial, but if you give them radiotherapy too soon, for example, within after 2 weeks of surgery, it's not good. And we always think it's about the wound healing and waiting for the wound to heal. I mean, not really. But the most important factor here, not to give early radiotherapy, is actually have negative impacts on survival. Because in the period few weeks after surgery, there's a lot of edema and hypoxic or ischemic changes at the tumor bed, and that would decrease your radiosensitivity. That's one point. The other point, after resection, you get a cavity here, and you need to give some time for this cavity to collapse or to shrink. If you give it early before this collapse, that means you're going to increase the radiation field, okay? And you give more radiation to normal brain, and also that will affect the recovery, brain recovery, okay? Late radiation, if you give it after 6 weeks, again, showed that it's not good, because if you give it after 6 weeks, you will be worried about the progression of the tumor. We know GBM is a very fast growing tumor, and this by 6 weeks, the tumor might, after 6 weeks, I'm talking about 8 weeks, for example, after 6 weeks, the tumor will increase, progress, and you have more growth of tumor. And we know this, what we call complex tumor growth, which is this curve, this principle tell you that when the tumor grow more, the mitosis become less, and that would make him less sensitive to radiation. This is well known to radiation therapists. And I found this interesting study published recently, comparing the different stages of radiotherapy. When you give it early, less than 28 days, 28 to 33 days, or more than 33 days. And they found that the 48 days actually, which is, 6 weeks, considered bad for starting radiotherapy. The 3 group, there's no significance. So their recommendation and the current recommendation, even our center, will probably 4 to 6 weeks is the good time to give radiotherapy. Not to give too early, unless you have really aggressive tumor and it came back and you have to operate again, and this tumor behavior is really bad. You can start early, but not less than two weeks, okay? But the current standard is about 4 to 6 weeks. I would say I wouldn't go more than 6 weeks, for the reason I've just mentioned. So this is the chemotherapy now, agents. As I said, there's a lot of chemotherapy agents tried before, PCV, Carmestin, etc. But temozolomide showed interesting and good results. And this is a famous paper. Residents need to know about it. A stop protocol published, in New England Journal of Surgery, 2005. And it's a big number of cases, 573, 85 centers. Again, at that time, they didn't test the MGMT or IDH. And you can see 60% of patients had biopsy, 44 partial resection, 40% had complete resection. And that would reflect of the survival. The median survival was 14.6 with the tumor. When you give radiotherapy with concomitant temozolomide, the protocol was, temozolomide with the radiotherapy for 10 days, and then you have 6 cycles of temozolomide given over 5 days every month over 6 cycles. So the duration of treatment is 6 months, okay? Median survival 14.6 compared to 12 that did not receive temozolomide. I mentioned here the effect of temozolomide, how does it work? And this is the pathway. We talk about epigenetic regulation, or the methylation here. And that's why we use the term methylation, because this is epigenetic, okay? And this is how does it work. So the MGMT is the gene that disrupt the DNA replication. So hypermethylation results in reduced expression of GMT, thus impair ability of cells to repair damage induced by chemotherapy. So if it is methylated, this tumor will have less ability to repair itself after damage caused by chemotherapy. And that's a good thing. Okay, so later on, we knew about the MGMT, methylation, better prognosis, and they are found in almost half of the patients. 45% of GBM, they have methylated GBM. But even the patient who have non-methylated, their recommendation is to give the temozolomide, because they saw also some improvement even if they have non-methylated MGMT. Again, more controversy about the temozolomide treatment. Some people, some studies suggest to extend the first course of temozolomide with the whole course of radiotherapy rather than only 10 days. And some studies showed benefits, improvement in survival. And some studies also showed that you don't need to start temozolomide immediately with radiotherapy. If you start it after radiotherapy, the results are the same. Some study extended the 6 cycles to 12 cycles. So there are lots of controversy, but the protocol now, which is all acceptable, is 6 months for newly diagnosed with good prognosis, less than 70 temozolomide. If it's above 70 and you treat it as palliative, you can extend up to 12 months. Okay, now this is something I would like to mention because it's mentioned in the guideline, and this is something that we used to do in the UK. Actually, it became very popular in Europe, late 1990, from 95. It's used for recurrent GBM, then was approved for newly diagnosed GBM. So because think about it, chemotherapy doesn't normally penetrate well blood-brain barrier. So why don't we use chemotherapy in the tumor bed, on the tumor itself? And the common one was known at that time as the carmazine. PCNU was used for as a chemotherapy agent for brain tumors, but the problem is it doesn't penetrate very well blood-brain barrier. So they manufacture it for local release in the intraoperatively. So what you do, we have this, what we call them, we used to call them gliidal waivers. And you can see the pictures here. So you do the resection. It's like a capsule. You put them in the cavity. Okay. You should not use so many capsules. I think 4 to 8 capsules we used to use, depending on the size of the cavity. And you need to be careful not to open the ventricles, because if you open the ventricles, they can cause some toxicities and affect the healing. Anyway, it showed some improvement overall survival for recurrent GBM. This was first published in 95. Then for newly diagnosed, published in 2003 by Westville, a phase 3 trial. And overall survival improved for 13 compared to 10 months for radiotherapy surgery or radiotherapy and the radiotherapy. The side effects, the major side effect was for this treatment was brain swelling. I've seen a couple of patients died from massive brain swelling after inserting gliidal waivers because it can induce a lot of brain swelling, seizures, some problem with increased wound infection. Again, that's not being confirmed. But anyway, it's not available in Saudi. People still use it, in Europe, especially for recurrent GBM. Now, after stop protocol published 2005 showed a slightly better beneficial of overall survival went to 14 months. So that's why people stopped using the gliidal waivers because of basically the side effects. And with the stop protocol, the survival was slightly better. So that's why people stopped using, or becoming very less popular, if we can say that. Now, tumor treating VTTF, this is something also, showed good improvement in survival. But the problem with this treatment, obviously, this is also published in 2015 by same group. They did the stop protocol. Previously, some studies showed that electric field can cause mitotic disorder by disruption the mitotic spondyloform. Sorry, I have to write this so I don't forget about it. So basically, it affects the mitosis of the tumor and cell growth. The problem with it is the practicality first, because the patient has to shave his head all the time, which is not a big problem, but you have to wear it for more than 18 hours a day. The time you receive the temozolomide. So we're talking about 6 months treatment, and the survival improved up to 24.9 months compared to, as I said, stop protocol was, as I mentioned, 14.6 months. So this is, significant improvement, and it's only used for supratentorial, obviously, tumor. but its practicality and the cost effectiveness is something of a huge concern. You know, $20,000 per month. So the cost of treatment is about $120,000. Not everybody can afford it, especially, you know, where countries, the governments are paying for the treatment. In UK, if you see the NICE guideline, would tell you don't offer this for newly diagnosed patient because of the France as well. Cost effectiveness is a major concern. And you need to have really good insurance company to pay for it. So that's the guidelines, the treatment of GBM. So I'm just going to give you now some tips, clinical tips of how do you manage GBM. And first of all, I want to show you this because I think this is very important to show to the residents to understand the stage of treating patient with GBM and when do we involve here as a neurosurgeon. As a neurosurgeon, especially in Saudi, we are involving, if you are in the oncology center, you know, you will be involving with the treatment of GBM throughout all the stages. So we have the stage, you need to look at it as the patient with GBM as a journey. You know, you have to take him through this journey. This journey is short. It's 6 months up to 2 years. If he's lucky, it'll be more than, you know, 3 years. You have to, you know, understand all the steps, the stages that this patient will go through, starting from diagnosis. You get involved here because you have to provide surgery and pathological confirmation. Between surgery and starting the treatment, radiotherapy and temozolomide, you have to deal with your complication, post-op surgical complication. Between starting temozolomide, finishing temozolomide, which is 6 months, you will be involved because a lot of issues can occur here, pseudo-aggression or radiation effect. You'll be consulted. Between finishing radiotherapy, temozolomide, and having progression or recurrence, again, you'll be involved because this is a stage where you get the progression or recurrence. You'll be consulted again, you'll be involved. And this is between progression and recurrence to, you know, providing more treatments or palliation, you'll be consulted again. And this has to be always discussed in the MDT, each step of this treatment, because that would be probably the best approach to these patients. And you need to know these are stages and you have to be involved throughout. The problem with I mean, in Saudi, we don't have many neuro-oncologists. I mean, neuro-oncologists will probably take over or ease the pressure on you, but most of the management of brain tumor here done by people who are not neuro-oncologists. They don't like brain tumors, and they always, you know, like your advice and your involvement in the management of these patients. Okay, so very important to understand the journey and different stages of treating patient with GBM. Another tip here, I'm sorry, I have to go through this very quickly. You know, sometimes you'll be faced by cases where, you know, you're not sure, is this a GBM or not GBM? Shall I go for resection immediately? Shall I take a biopsy? Because a lot of conditions can mimic GBM, like infection, MS, vasculitis, etc. And you need to rely on the clinical picture and radiology and the presentation, sudden onset, you know, gradual, other, you know, manifestations, other changes on radiology. But my advice, if your radiologists are not happy, whether this, for example, this ring enhancing lesion, is this infection or METS or GBM, go for biopsy first. There's no harm taking biopsy first. But when you take a biopsy, take it from the wall. Don't take it from the cyst. And I always like to do a mini craniotomy, open guided biopsy with navigation, see the wall itself, take a biopsy from the wall, big sample, control any bleeding. And I know people like to do stereotactic biopsy. I personally don't use it unless it is really deep in the thalamus. But send the biopsy from the wall, send it for culture, for pathology. And the other tip I would like to give you, do not give any result to the family before having final pathology. I mean, I have similar case, ring-enhancing lesion. The smear or the frozen section was inflammation by the pathologist. And I gave the news to the patient. Excellent, good news. You know, it's infection, it's not a tumor. 5 days later, the final pathology came back to GBM. So do not rely on the frozen or the smear initially. Wait for the final pathology. That's my advice. This is a case, again, looks like GBM that we did the biopsy to start with, because their presentation was actually very odd. It was actually TB. This is MS. Okay, so that's another tip. This is a big question now for you guys as a resident, as junior neurosurgeons, what to do about resection. Shall I do biopsy? Shall I go for resection? Because you need to decide when you have a patient with GBM, is this patient going to be for palliative, or shall I go aggressive or provide him with what we call full therapy? And I call it full therapy. Full therapy, that means good resection followed by, stop protocol, temozolomide radiotherapy, 6 months. That's full therapy. So you need to consider so many factors. Study the case from different aspects. You need to look at the age of the patient, his performance, and comorbidity, neurological deficit that reflect on the performance, basically, because these factors are very important in your decision. Look at the radiology, location, the size. Is it multiple? If it's near the elegant area, look at the functional MRI, DTI, and then look at your resources. If it's a non-elegant area and I could do good resection, go for it. If it is an elegant area, require further, awake craniotomy or intraoperative monitoring, you don't have it, refer this patient. But also remember, you have something called stage surgery. You can, if you think I've done most of the resect the tumor, then post-op MRI scan has to be done within 48 hours. There's still big residual. I can also go back. There's no shame of doing this, going back again, speaking to the family and the patient. And you always think about achieving the threshold, which is, if it's enhancing parts, you can, in a place you can resect it all, do that. If it's a minimum of 80%, 90%, go for it, but always try to provide a big resection. And what is important for me is not just the amount of resection, and there's a studies show that very clearly, the residual and the mass effect. Because if I have a big tumor and I resected 90% and the 10% is still big and causing mass effects, again, that's not as good as having a small tumor like this tumor, for example. And if you resect, 50%, the residual is very small. Your radiation oncology would be happy if you leave such a small residual. So think about residual as well. Think about the impact on postoperative deficit, okay? And I've seen this in a lot of papers. The 4 months survival benefit that you will get by resecting the tumor or doing more, going for enhancement and the flare, etc. This 4 months benefit will be lost if you give this patient a deficit, serious deficit, hemiplegia or speech disturbance or cognitive disturbance. So you have to balance this, okay? And I've seen studies that show all this, the benefit of resection would be the 4 months lost significantly if you give, and I'm sorry, I didn't mention this paper here, but you need to remember this, okay? The post-op morbidity, neurological deficit has big influence. And if you bring to the tumor board patient you did total resection, but brought him hemiplegic, believe me, the next step will be palliative radiotherapy and, poor survival. So remember this, and remember the studies that we've shown here, some of them really selective, you can tell okay, 70% of these patients had 100% resection. Okay, if you look at their criteria and the selection, you would be selective. So don't be ashamed or feel sorry for yourself if some of these patients referred for palliative and you can't, well, I'm sorry, I can't resect anymore, because, this is the case. A good number of GBM would be palliative from the start, because we cannot resect more than 80% or 90% because of the multiplicity and location. like this example, patient extension, midbrain, brainstem. So it's fine. If this patient referred for palliative, it's okay. And most important thing here is just consult with the patient and the family. And you need to tell them, you know, yes, I can resect more, I can give you, but I might give you some morbidity, and hey, let him get, you know, be involved with the decision. One tip I need to mention here, the complications, okay? Especially, we know all about the complication. Infectious CSF leak is really serious, because if you have infection post-operatively, this will delay the starting radiotherapy. And unfortunately, we do receive patients from other hospitals coming with infection or CSF leak, and that is a major problem for us, because until you treat the infection fully, you know, it might take you another few weeks, and you know, that will delay starting the treatment, adjuvant radiotherapy, chemotherapy. And my advice, and that's what we do, be aggressive with the infection. If patient come with pus coming from the wound 2 weeks after surgery, be aggressive. Go back, remove the bone flap. You know, if it's another craniotomy like meningioma, you can always start with the, you know, I can say, okay, I'll give him antibiotic for 1 week, 2 weeks, and then see what happens. We don't have time here. If you have infection, my advice, take the bone flap, do the debridement, clear the pus. CSF leak, go for lumbar drain or a drain, you know, repair immediately, because any CSF leak more than, you know, a few days, infection, and then delay in treatment. So you have to be really prompt and aggressive treating post-op infection or CSF leak. Pseudo progression, again, I have to go quickly now because of time, but remember, pseudo progression, this is where you see that, and you'll be consulted about it after finishing radiotherapy. So at the end of radiotherapy, between 4 to 12 weeks, patient might show some progression of his enhancing part on the follow-up MRI scan, and you get, you know, for example here, you know, 3 months after MRI scan, you think the tumor is back, negative biopsy, and you will be consulted. And I always be, you know, we'll have this discussion MDT, oh, this tumor is back now, and I always say, well, please wait, repeat the MRI scan, because there was so many factors here in explaining why you will see more enhancement after starting the treatment, because after the treatment you will get you know, some ischemic changes, the blood products, disturbance of the blood-brain barrier, and that's why you get some enhancement. It happened in, surprisingly, up to 30-40% some disease of the patients in GBM treatment, they will get what we call pseudo progression. Interestingly, patient with methylated MGM, they have higher incidence of doing pseudo progression, seeing pseudo progression. And a lot of images can be done here. I know people suggest MR spectroscopy, perfusion studies, PET scan, etc. But to be honest with you, according to the you know, the advice of radiologists, they're not conclusive. And the best thing to do is just to follow them with repeat MRI scan 6 weeks or 3 months, especially if the patient is not symptomatic. Okay, and this is really important criteria to decide about the response of disease after treatment. It's called Rhino criteria, published 2010. It's very important. A lot of people use this criteria, defining what we call complete response. You have partial response, stable disease, or progressive disease. And you need to look at the MRI follow-up of the patient on steroid, their clinical status. That's why when we discuss this with you, I always ask them, what is the status of the patient? Is he on steroid or not on steroid? What's he like? You know, follow-up. Okay, and this is very important to decide about progression, real progression from pseudo progression. Again, sometimes you might need to deal with radiation effects, and radiation effects after treating GBM also can be acute, divided, or subacute, or chronic, or what we call radionecrosis can happen late. So there's different mechanism of having radiation injury, you know, again, patients can be admitted again in acute stage after radiation with the brain edema, and they have to have really massive big dose of radiotherapy. Of steroid. The subacute, you can get some enhancement. This is what we talked about, the pseudo progression. Obviously, there's the border between pseudo progression or radiation subacute changes is vague. The late delay, this is what we call radionecrosis, and this is ischemic changes. Okay, and sometimes, I mean, I've done that a couple of times. We have to operate the patient with radionecrosis because of the mass effect, and which is not responding or swelling, not responding to steroid. Some people suggest Avastin because it's like a huge, strong steroid in treating these cases. Recurrence, this is again, so we have finishing the treatment and we pass through the phase of pseudo-progression, etc. Then we have the tumor would recur at some stage. The average is normally 6 to 9 months, but until becoming really clinical, it would take probably 9 to 14 months from diagnosis. And options here, we can see a long list of chemotherapy used. Avastin, Visicum, is the most popular now. That's what we use, plus inotecan in our center. And it's showed really good benefits for recurrent. I think this paper, so I didn't put it here, it's 2010 or 2008, actually showed some improvement in survival with Avastin plus inotecan. They call it salvage. If you read about something called salvage chemotherapy or second-line chemotherapy, this is what we're talking about. So it's a second-line chemotherapy. Some people will try, if the recurrence happened long time after the finish off the temozolomide, some people try temozolomide again. Okay, there's always rules for re-irradiation, and you should consider surgery. In some cases, I'll just show you the study we did locally here to tell you what we've done for this recurrence cases. And other option is palliative. So this is one of our cases, really show the good response. This is after starting. This is a recurrent case. I think this was 54, local recurrence, and he refused surgery. And we tried Avastin after a few months. This is the result. So the Avastin is target therapy, we call it. It's a monoclonal antibody, block the angiogenesis. That's why very effective for brain swelling. This is, I'll just show you quickly cases we treated here between 2010 and 15. 40% of our patients came in with really poor performance and extension of disease that we couldn't do good surgery on them. I mean, we used to be less aggressive. I think people tend to be more aggressive nowadays, and we send them for biopsy and radiotherapy. 33% had full therapy, okay, and then when they progress, we divide them. If there's local recurrence, we can go back and operate again. If you can't, like this case, you can consider chemotherapy, second-line chemotherapy. Interestingly, the time of recurrence in our cases, I have to mention this, we don't have the IDH or the MGMT. It's the average of the mean is 13 months. Patient who had the surgery, their recurrence happened after 16 months. The average, and the survival since progression is 8 months for patient who had nothing, nothing or second-line chemotherapy. Patient has surgery plus or without chemotherapy, the more survival. If you look here at the overall survival from diagnosis, if the patient had no reoperation after recurrence and no more chemotherapy, just palliative, the overall survival was 13 months. Which is acceptable internationally. If the patient had no further surgery and have second-line chemotherapy, their survival was 27, over 7. This is from diagnosis. Patient had no surgery and no more chemotherapy. They have overall survival 25. The patient had another surgery, but no chemotherapy because went into palliative. They lived to 25 months average, or the mean. Patient had resurgery and second-line chemotherapy that lived up to 30 months, which is really acceptable internationally. Again, there was no significant statistical difference between the group, between having surgery plus second-line chemotherapy or second-line chemotherapy alone. Okay, so you can either give second-line chemotherapy or consider surgery plus the second-line chemotherapy. And I think I'm going to stop here, and if there's any questions to take, please go ahead.
Thank you very much, Dr. Taha. I think you went and covered all the question they mentioned. There is one question. There is one question asking about the TTF availability in Saudi Arabia, and if not, have you ever sent patient outside to receive this medication?
It's not available, and I did not refer any patient to outside Saudi. I think other colleagues might have done. I mean, I don't know. I mean, $120,000. I mean, unless the patient insists and he's, you know, he's happy to have 18 hours a day of wires stuck to his head. I mean, I don't consider it as a cost effective, and the benefits showed here is actually with the newly diagnosis from the start. So if you want to give TTF based on the study, it has to be with the stop protocol. Now, if it is effective for recurrence, I'm not sure about how effective it is for recurrence, but based on the study that was published, to get the maximum benefit, you have to start it from the beginning with your stop protocol. So that means, you know, you need to get this treatment provided for this treatment, for this patients here in Saudi from the start. Otherwise, we have to send all GBM cases abroad from the start. Once you have GBM, send them abroad to have the treatment abroad where the place they have TTF. And this is something major. I mean, in Europe till now is not recommended because of this. I mean, in the UK, I mean, I mentioned this nice guideline tell you do not offer this treatment for newly diagnosed GBM. Okay.
We have a comment from Dr. Abdulrazak that there is a important negative study in the Avastin 2 New England Journal is newly diagnosed GBM, another point in an oncology point.
The paper on, so I went through the, and I remember the study on for newly diagnosed Avastin. I don't think showed benefits, big benefits, and that's why it's not included in the guidelines. These guidelines actually, it's 2018, the latest NCCI guidelines, because the benefit of Avastin for newly diagnosed GBM is not, I don't think it's significant, and that's why it's not mentioned in the guidelines. We'll try here to cover the guidelines. There's the study in 2008, I think, for recurrent. I'm not aware for newly diagnosed, I'm not aware, and as I said, we try to cover the guidelines that's been recommended recently. I mean, if it is newly studies showed benefit, I think in the next guidelines, people will talk about the dendritic cell vaccine, because this study showed significant, we talk about 3 years survival of these patients. But again, same thing, the cost is around you know, $100,000 per setting, because you have to it's like a bone marrow stem. You have to take the cells from the body and manipulate them and then inject them again. It's very costly, but luckily it's not on the guideline. In the guidelines, the TTF, I mean, I mentioned this, it tell you can offer to the patient plus minus, so you have the option. You don't need to offer the TTF for these patients.
We receive a question, multiple question about the same point, and we encountered it in previous webinars, and we will address it now more. We have a couple of questions about how many surgery you can go if the patient is clinically intact.
You mean for recurrence?
Yes.
Well, if the patient is intact and it's a focal recurrence, you could go as many as the patient require. I mean, I've done, the maximum was done is 4 cases for recurrent. I mean, some patients, for some reason, they recur locally. You know, so you see them every 6 months or 12 months, you know, with local recurrence. and they are in good shape, the tumor in non-elegant area, and if you can offer them surgery, of the patient happy, go for it. There's no limits. I mean, but I think 3 is probably the maximum you can go, because after a 3-time recurrence, most of these patients will be, the tumor recurrence will be multifocal, be spreading into the deep seated parts and the corpus callosum or thalamus or deep parts. So you're going to be really lucky to get a patient with multiple recurrence in the same place. This is very unusual.
Okay. We have a question about how can we differentiate between the edema and between, let me read the question exactly the same. So how to differentiate between edema and tumor and FLAIR imaging?
Well, the FLAIR T2 images show you more. I think what you see signal on the FLAIR, it's represent more tumor infiltration rather than edema. I think you can go with compare with the T2 and always check with your radiologist. I think the other helpful thing, which is, to be honest with you, the fluorescent, intraoperative fluorescent also can help you distinguish between non-enhancing tumor or enhancing tumor, infiltration outside the enhancing part of the tumor. With experience, I think surgeons also, they can, tell you this tissue is a normal tissue or this is infiltrated by disease. But when you see signal changes around the tumor on the FLAIR T2, the pictures I've shown you, this would make you, thinking more of a tumor infiltration rather than edema. And I'm not, proposing here that everybody should have his FLAIR area resected, okay? But it's really depend on the location of the tumor. And I've seen, I know Dr. Ajlan like this, and we have, and also, I know Dr. Wissam and Isawi here are really aggressive surgeons, and people now thinking about what we call, the maximum supra resection of the tumor, go more than enhancing. And if you do that without causing neurological deficit to the patient, I think you should consider it based on the study that we've shown. Because we all know that the recurrence of the tumor always happen within, I didn't mention in the presentation, tumor recurrence usually happen within 2 to 3 centimeters of the enhancing part of your resection. And that's why if you can resect 2 centimeters beyond the enhancing part without damaging the patient, it is always better, because this is where you expect to get the recurrence. And that's why the radiation field, when I mentioned this in the presentation, the radiation field go 2 to 3 centimeters beyond your resection, because they know this is where the area of the tumor can come back, can recur. 90% of the recurrence happen within 2 to 3 centimeters from the tumor enhancing field.
We will conclude with this question. From your experience, is there any difference in progression, in prognosis between the adult and children? Is it better in adult? Is it better in children?
It's a good question, but I think the problem with the pediatric, as we talked about in the previous presentation, they are not one tumor. In adults, most of them, it's the IDH wild type. So we know it's almost one pathology with molecular. IDH mutants, it's a secondary GBM. It's so we have either wild type or mutant. But in children, the subtypes of high-grade glioma or GBM, it's really mixed, because we have the IDH mutant is very rare. The other wild type, they have a lot of sub-classification, including the GR34 and the the deep-seated one, you need to think about the K27 midline glioma. So it's not one disease in the children. That's why the prognosis is variable. And unfortunately, the children, majority of the patients are actually in the deep size, deep midline gliomas. But if they are superficial, lobar, and if they're wild type, I think their prognosis is better than the adults. But in the kids, it's a different story.
Thank you very much, Dr. Taha. It's well-instructed lectures and update about the management of glioblastoma. I would like just to remind everyone about our SANS Academy channel on YouTube, where all the webinar will be available, and also our Telegram channel, so you can get updated about the webinars. Thank you very much, Dr. Taha, and for the attendee.
Thank you.